Good morning and welcome to today's Journal Club. My name is Eyal Robinstock. I'm an endocrinologist and thyroid cancer specialist from Israel, and I'll be the host of the meeting today. We have an outstanding program about ethanol ablation in papillary thyroid cancer, and it's my pleasure to introduce our two wonderful guests. First, Dr. Pål Stefan Frich from Norway will present his work published in the JCEM this year about long-term follow-up after ethanol ablation. And Dr. Frich is a radiologist from the Radium Hospital, a highly specialized cancer center in Oslo University Hospital. He graduated from the Norwegian University of Science and Technology in Trondheim and started his residency in radiology in 2014. He's board certified since 2019, and today his practice is focused on diagnostics of thyroid cancers and sarcomas. His work that he'll present today is a part of his ongoing PhD project. Following Dr. Frich, we're happy to have a distinguished discussant from Mayo Clinic, Rochester today, Dr. John Schmitz. Dr. Schmitz graduated from Creighton University School of Medicine in 2007, completed his radiology residency at Mayo in 2012, followed by a body imaging and intervention fellowship at Mayo in 2013. He's an assistant professor of radiology, and his practice focuses on interventional radiology, including interventional oncology. Pertinent to the meeting today, Dr. Schmitz performs ethanol ablation for metastatic thyroid cancer in the neck and RFA of benign and malignant thyroid nodules. Thank you both for joining us, and we'll start with Dr. Frich's talk, which is pre-recorded. He'll be with us later in the Q&A session that we'll have after the two talks. Dr. Frich, the stage is yours. We have no sound.
And the opportunity to present our work at today's session. Before we start, I should give a short statement that I have no potential conflicts of interest in relation to this presentation. And as you can see, the study was funded by grants from the Radium Hospital Foundation and Edgar and Freemondals Foundation in Norway. Let me start by saying a few words about my own background. My name is Pål Stefan Frich, and I work as a radiologist at the Radium Hospital in Oslo, which is a part of Oslo University Hospital and is a highly specialized cancer center in Norway. I also do my PhD degree at the University of Oslo, where I do research on thyroid cancer and with a focus on ultrasound-guided ethanol ablations. In this photo, you can see the main building of the Radium Hospital just a few years after the opening in 1944. And in this next photo, you can see how the same area looks today. On behalf of myself and my co-authors, I'm happy to be able to present the results of this study that we published in the Journal of Clinical Endocrinology and Metabolism a few months ago. This is a long-term follow-up study in which we re-examined patients who had previously received ethanol ablations for recurrent neck node metastasis from papillary thyroid cancer and who were included in a study published by colleagues at our institution in 2011. And this is still the largest published group of patients treated with ethanol ablations in PTC neck node metastasis. So the aim of our study was to evaluate the long-term efficacy and safety on ethanol ablations as an alternative to surgery for metastatic lymph nodes from papillary thyroid carcinoma. As you probably know, lymph node metastases to the neck are very common in adult patients with PTC, both preoperatively or during the initial surgery, but also later in the patient follow-up. This is despite the fact that the primary surgery was made with a curative intent. And because of the indolent nature of the disease, these recurrent lymph nodes could normally be discovered months and even up to several years after the initial diagnosis and treatment. High-resolution ultrasound plays an important role in the diagnostic of neck metastasis from papillary thyroid cancer, both in the preoperative setting with staging of the patient, but also during follow-up in order to detect any recurrent lymph nodes on the neck. Most of the lymph nodes are found in the central compartment or the anterior lateral compartments, and to a lesser degree in other neck regions. There are certain typical characteristics that we can look for when trying to identify the suspicious lymph nodes for metastasis from PTC. One of those are enlargement of the lymph node with loss of fatty hilum and often a rounded shape due to the expansive growth of the tumor cells in the lymph node. Lymph node metastasis from PTC can also be hyperechogenic, and they can have calcifications in the metastasis. Another feature, which is not as common but still quite typical, is cystic change in the lymph nodes. And finally, we will always assess the vascularity, which is often increased in metastasis from papillary thyroid carcinoma. And this is also an important thing to assess during the follow-up after ethanol ablations, as the absence of vascularization is considered one of the criteria for successful treatment of the lymph node. The treatment of these recurrent or persisting lymph nodes remains a clinical dilemma. It's even getting more complicated in the last decades due to the introduction of better diagnostic tools such as the high-resolution ultrasound and the thyroglobulin washout samples, which has led to more and smaller metastases to be detected. Traditionally, the treatment of choice for recurrent disease has been surgery. There is a problem, however, when the recurrence occurs in a previously operated region, because the surgery could be complicated with scarring, changes in the anatomy and tissue planes, which could lead to more complicated procedures and increased risk of complications. There are several studies that have shown that reoperations could be performed in previously operated neck region with good outcomes and an acceptable risk of complication. However, they are emphasizing the importance of this being performed by surgeons with extensive experience in revision surgery. The current guidelines still state that surgery is the preferred treatment, but several mini-invasive treatments have subsequently emerged as an alternative to revision surgery in selected patients. The current recommendations for ethanol ablations state that this could be considered an alternative in patients who are not suitable for surgery and who have a limited number of neck node metastases. It is also emphasized that repeated sessions of ethanol ablations often will be necessary to achieve an adequate response in the lymph node metastasis. The first study publishing the results from ethanol ablation treatment in metastasis from PTC came in 2002. And since then, several reports have been published that have shown promising results from the treatment. The studies are, however, limited by a small number of patients, and the lymph node metastases are usually quite small. There are also relatively short follow-up times in the published studies on this treatment. As I mentioned earlier, the patients in our study were also participating in a study published by colleagues at our institution in 2011. In this study, a total of 109 neck node metastases in 63 PTC patients were examined, and 93% of the metastatic lymph nodes were reported to have responded to the ethanol ablation treatment. All the patients from this study had undergone a total or subtotal thyroidectomy and was also treated with one or multiple sessions of iodine ablations. All the patients had 3 or fewer neck node metastases at the time of inclusion in the first study. And so to the protocol of this follow-up study. We started by identifying the patients from the original study, and we're sending out invitations to participate in this long-term follow-up. And for those patients who gave their consent to participate, we did obtain relevant information from their medical records and from the radiological journal systems. All the included, as well as the deceased patients, were staged according to the TNM 8th edition. We then scheduled re-examinations of the included patients on a patient basis. We did a roughly ultrasound examination of the neck and also performed interviews by an endocrine surgeon. We obtained blood samples for analysis of relevant blood samples as stated on the slide, and we registered and evaluated any adverse effects from the treatment. In the case we found any suspicious lymph nodes during the ultrasound examinations, we performed final aspiration biopsy with cytological samples and also FNAB TG needle wash specimen for the analysis of thyroglobulin in the washout samples. Whenever we found a metastasis and there was a clinical indication for new EA procedures, this was performed, and then usually after multidisciplinary discussions. The recurrences in this study were confirmed by morphological confirmation on the cytological samples and or thyroglobulin values in the washout sample that was greater than the thyroglobulin in the patient's serum. And we also defined recurrent disease in a location where ethanol ablations had not been performed as a recurrence outside of previously EA-treated lesions. We also refer to this as new lesions. The criteria for satisfactory treatment response from ethanol ablations were similar to the criteria in the original study. The first one is complete disappearance of the lymph node, and most of the lesions with a satisfactory treatment response were fulfilling this criteria in both the original study and in our follow-up study. The second criteria was a reduction of the anterior posterior lymph node diameter to 4 millimeters or less, and there should be no sign of vascularization on the Doppler ultrasound at follow-up. The third criteria is a normalization of the lymph node in size and appearance, in some cases a scar formation. The fourth criteria is if the lymph node does not fulfill any of the other criteria, then you do the final aspiration biopsy with cytological smear, and there should be no detectable thyroglobulin in the washout samples. The procedure of ethanol injections is technically relatively simple. We use a thin needle and ultrasound guidance in order to place the tip of the needle within the lymph node metastasis. A small amount of pure ethanol is then injected in the lymph nodes, and typically the position of the needle has to be adjusted during the injection to ensure that the entire metastasis is treated. The amount of ethanol injected varies somehow, but is usually between 0.1 and 1 milliliter of ethanol. Let's look at the flow chart showing the included patients. As you see from the top of the flow chart, there were 63 patients eligible for inclusion from the original study, and we managed to re-examine and include 44 of those patients in the new follow-up study. The median age at follow-up was 63 years, ranging from 35 up to 86 years. There was a slightly predominance of female patients in the included group, and there was a quite long interval since primary surgery with a median of 14.5 years. We found that 7 patients were deceased since the end of the original study. The median age at death in this group was 68 years, ranging from 55 to 82 years, and the vast majority of patients in this group were female. The median interval from primary surgery to death was 11 years. We obtained information from the medical records, as well as the cause of death registry in Norway, and found PTC to be the cause of death in 3 of these patients. One of these patients had stage 2 disease at initial diagnosis, while the 2 remaining patients had stage 3 disease. From this slide, you can see that the 44 re-examined patients represented 67 of the 109 neck node metastases in the original study. The group of deceased patients had 15 of these metastases, while the remaining 27 metastases were distributed among patients which did not give consent to the study or were excluded due to other reasons. So we are ready to move on to the next part of the presentation, where we will present the results from the study. I would start by showing you the distribution of the TNM status and stage for the included patients, as well as deceased patients. As you can see from the table, the distribution of T status was quite uniform in both groups, with no significant difference. When it came to the nodal status, we saw that most patients had N1 status with known lymph nodes at the time of initial diagnosis, while a smaller amount of patients were without any known metastasis at the primary diagnosis. There was a slight difference between the two groups, the included patients and the deceased patients, when it came to disease stage. As you see, most of the patients that we included in the study are having stage 1, that's 81%. But if you take a closer look at the deceased patient group, you can see that a greater amount of patients in this group had stage 2 and stage 3 disease. As I pointed out in the first part of this presentation, the current guidelines are emphasizing that repeated ethanol injections may be necessary in order to obtain a satisfactory treatment response from ethanol ablations. In our follow-up, we found that most of the re-examined patients had had a limited number of ethanol ablations and in a limited number of lesions. 87% of the patients had had ethanol ablation treatment in 1 or 2 neck node metastases. There was a median of 2 ethanol ablations in each lesion, and almost 90% of the lymph nodes had been treated with between 1 and 3 ethanol ablation treatment sessions. 80% of the patients had been treated in just a single neck region, while 18% had received ethanol ablations in 2 regions and only 2% in both central compartment and both lateral compartments. What we reported as one of the main findings in this long-term follow-up was that local control was achieved in most patients, also in the long term. We had a follow-up time of 11.3 years since the last ethanol treatment of the lesions, and we found that 80% of the patients were without any ultrasound detectable disease on the neck at the time of follow-up. Almost all the re-examined lesions in the study had fulfilled 1 or more of the response criteria at the end of the original study. In this follow-up, we found that recurrence had occurred in 19% of the ethanol ablation treated lesions. 9 of these 13 recurrent lesions were undetectable at the end of the original study, and thus fulfilling response criteria number 1. The 4 remaining lesions were still visible, but were fulfilling 1 or more of the criteria 2 to 4, and were therefore considered to have had a satisfactory treatment response. 10 of the recurrent lesions were found in one of the lateral necks, and 3 of the lesions were found in the central compartment. Let's now look at the next slide, which shows the time course of the recurrent lesions found in this study. First, let me quickly explain the figure. If you look at the top line, you can see the time follow-up to the right, and the rest of the line is representing the years ahead of the follow-up. And marked in the box to the left is the sessions of the initial ethanol treatment in these recurrent lesions. And here you can see that the closed lines are representing series of more than 1 ethanol ablation, while the vertical lines would represent 1 single ethanol treatment. All the lesions were considered to be satisfactorily treated, and the ethanol treatment was therefore discontinued. If you look at the right part of the figure, you will see the time of recurrence for these lesions. As you can see, 7 of the 13 lesions were detected ahead of the follow-up examination in relation to this study. Except 1 lesion being referred for surgical treatment, the remaining 6 lesions were all giving new ethanol ablation treatments. But only 1 of these lesions were obtaining an adequate treatment response. We found a total of 6 recurrent lesions in relation to the follow-up examination in this study. Lesions were distributed in 5 patients, and the treatment was chosen after discussions in a multidisciplinary meeting. 2 of the patients with 3 of the lesions were referred to surgical treatment. We decided to follow 1 of the lesions with active surveillance, while new ethanol ablations were given in 2 lesions in the remaining 2 patients. As I pointed out earlier, only 1 of these recurrent lesions were successfully treated by repeated ethanol ablations. We presented this case as a part of our study. To the left, you can see the ultrasound image of the lesion ahead of the first ethanol ablation treatment in the original study. The image in the middle shows the lesion after 1 single ethanol ablation treatment with injection of a total of 0.3 milliliters of ethanol. The lesion was then decreased in size and measured 4 millimeters, and there was no sign of visible vascularization, and as such, the lesion was considered to have been successfully treated and ethanol ablations were discontinued. 7 years later, we found increased size of the lymph node on the ablation site and with abundant vascularization. New ethanol ablations were given, a total of 4, and the lesion became undetectable and has remained so on subsequent examinations. Ethanol ablations must be considered as selective treatment of confirmed lymph node metastasis. And because of that, the risk of subsequent recurrences in locations outside of the ablation sites should be of a concern. In this study, we mapped a total of 22 new lesions in 27% of the patients. As you can see from this flow chart, 14 of the 22 new lesions were found in 7 of the 10 patients who also had recurrent disease in 1 or more of the previously ethanol ablated lesions. The remaining 8 new lesions were found in 6 patients who had no sign of recurrent disease in their previously ethanol ablated lesions. This distribution could indicate that the 10 patients with recurrent disease on the ablation site could have more aggressive disease and therefore having a larger number of new lesions elsewhere on the neck. And this gets more interesting when we look at the response of the ethanol ablations in these new lesions. As you can see on the slide, ethanol ablations in the 8 lesions found in patients without recurrence in the previously ablated lymph nodes had 100% response of the treatment. Contrary to this, the lesions found in the 7 patients who also had recurrent disease in previously ethanol ablated nodes had a response of only 43%, which is inferior to the overall efficacy and inferior to the response in the new lesions in the patients without any recurrent disease on the ablation site. We found that all the patients in the first group with durable response in all retinal ablation treated neck node metastases had stage 1 disease at initial diagnosis. This was true only for half the patient in the second group and could indicate more aggressive disease, but we found no statistically significant difference in distribution between the 2 groups in the study. As I'm approaching the end of this presentation, I would like to give some comments on the discussion and the conclusions from the study. Since the first report on ethanol ablations as treatment for metastatic lymph nodes from papillary thyroid cancer, there's been several other studies suggesting a favorable outcome of this treatment in this particular setting. Most of these studies are reporting size reduction, and there is a significant number of lesions that remains non-detectable on ultrasound after ethanol ablation treatment. This was true also in our study, where we found that 73% of the lesions remained undetectable in later follow-up examinations. We found that local control was achieved in most patients, and that this effect was sustainable also in the long term. The first reports of this treatment were showing low rates of local progression. Some later studies have reported the local recurrence rate of 16% and 24% respectively, and we consider this to be comparable to the recurrence rate in our study. Strain and colleagues found some differences between the initial size of the lymph node metastasis and the treatment response from ethanol ablations in their study. We were not able to confirm this effect in our material, but the numbers were small and uncertain. Ethanol ablations resemble a berry picking procedure, and as I mentioned earlier, the risk of recurrences in locations outside of the ablation sites are of concern. In this study, we mapped new lesions in 27% of the patients. And in 2 previously published studies, this is reported to be 9% and 24%. Most of these new lesions were found in patients who also had recurrence in 1 or more of the previously ethanol ablated lymph nodes. And as I showed you, the efficacy of ethanol ablations in the recurrent lesions in these patients were poorer than the overall efficacy. And this was contrast to the efficacy of ethanol ablations in the new lesions in the patients who did not experience recurrent lesions in their ethanol ablated lymph nodes. At last, I would like to summarize and present the conclusions from the results in the study. First of all, we saw that the study could bring some valuable long-term data for ethanol ablation as treatment for neck node metastasis and PTC from the so far largest published patient group. As I earlier mentioned, local control was achieved in most patients, also in the long run. We emphasize that the recurrence rate of 19% as well as the occurrence of new lesions in 27% of the patients, are confirming the need of close follow-up of PTC patients for a long time after primary diagnosis. The efficacy of ethanol ablation in recurrences in previously ablated nodes, as well as in the new recurrent lesions in the same patients, was inferior to the overall efficacy. And we therefore conclude that a lower threshold for the consideration of other treatment alternatives than ethanol ablations should be obtained in these cases. Finally, no major or persisting side effects were found in this long-term follow-up. This is in line with previously published reports. And as a conclusion, we state that ethanol ablation is a safe and efficient treatment, providing excellent result for a large group of patients also in the long run. We do emphasize that prospective studies comparing ethanol ablations to revision surgery, as well as more long-term results, are required. So before I end this session, I'm supposed to repeat my disclosure stages. So finally, I just want to say thank you for your time and attention. I'm looking forward to learn from your experiences in the following session, and we'll be happy to answer any questions then. So see you soon.
Thank you, Dr. Frich, for a wonderful talk. And now we'll have our discussant from the Mayo Clinic, Dr. Schmitz. I just want to remind everyone you can send questions through the Q&A box. And at the end of Dr. Schmitz's talk, we'll have a Q&A session. The stage is yours.
Yes. Awesome. Well, thank you very much for inviting me to chat today. I've certainly availed myself of Thyroid and Thank Foundation resources and learned quite a bit from those options. So very happy to have the opportunity to take part in this discussion today. I don't have any financial disclosures or conflicts of interest to share. During this talk, I'd like to review a few background statements on ethanol injection, talk about why this article that we're sharing here today is so important, and then talk a little bit about how we approach ethanol injection at the Mayo Clinic here. So when I was, reading this article, it was kind of like visiting an old friend because, I should say when I started doing ethanol injection a little over 10 years ago, my mentors, so Dr. Lewis, who was already referenced here before, Dr. Charbonneau, Redding, Lee, et cetera, Ian Hay, others handed me, a stack of papers to look at. And, of course, on top was the Mayo Clinic study that was originally done. But the second one was that study done by Dr. Hilo, which this builds upon. And so it was really nice to see this and have an opportunity to discuss this. So a little bit of background, 2015 ATA guidelines, what do they say about ethanol injection? So percutaneous ethanol injection for patients with metastatic lymph nodes is gaining interest as a non-surgical therapy. So not a super strong statement of support there. They do call it some limitations of the current studies, that they include small numbers of patients, relatively short-term follow-up, and many patients with small lymph nodes were studied. So those are some things we want to focus on as we move forward and try to advance this as a practice. We also talk about a general consensus is that PEI should be considered in patients who are poor surgical candidates. Many may need more than one treatment session, and nodes greater than 2 cm may be difficult to treat. I wouldn't argue with that. It does represent non-surgical berry picking, which is very true, and that formal neck compartmental dissection is still the first line therapy. Importantly, it highlights, when deciding the optimal strategy of care for patients, previous treatment modalities should be taken into consideration. And I think that really opens the door and keeps that door open to say, how does ethanol play a role after surgery, in between surgeries? Because as we know, surgery is not without risk, and surgery doesn't get any easier the next time, the next time, the next time. In 2015, JAMA Head and Neck, they had said, high quality, well-designed studies are needed to evaluate feasibility of incorporating PEI into the treatment protocol for PTC. Describe it as presently inferior to reoperation, but highlight it as having the potential to be a widely accepted and effective non-surgical treatment. So I'm not going to go through every study, and this certainly isn't every study about PEI out there, but these are a lot of the big ones. And I want to highlight a couple things. So how do we address those limitations that have been called out there? So if you look back, 2002, Dr. Lewis and colleagues here from the Mayo Clinic published their first experience there, 14 patients, 18 months follow-up. Great results, but not a big study, not a lot of follow-up. 2006, we had 6 patients, 18 months follow-up, 16 patients, 2 years follow-up. You get the idea here. 2011, we've got that study I already mentioned, Dr. Hilo and colleagues there, 69 patients and 38 months follow-up. So largest group there to date at that point in time. And then in 2013, Mayo Clinic republished an update with 60 months follow-up, so longest follow-up at that point in time. And then here we are, the present one. So Dr. Frich and colleagues, 124 months follow-up, by far the longest follow-up we have here. Still, I would consider really good results. And then a large portion of patients from that initial study made it through to there. So you can see the studies that we have that we're building upon here, not a lot of patients, not a lot of follow-up. So those are some of the things that we need to address moving forward. But if you do look at the results, I didn't highlight the results, but they're right after the highlighted portions here typically. I think very promising. So how does this study, that we're talking about here today, address the limitations? So, as we shared before, small numbers of patients, short-term follow-up, small lymph nodes. So again, as we pointed out, this study, larger number of patients, which is great. If we can get bigger, that'd be even better. But this has the most of any patient so far, and the longest follow-up. So two very important aspects of that, of those limitations. I would say the third is already in some senses tackled, but we can certainly address larger lymph nodes further. They define small lymph nodes in the ATA guideline statement there, as or reference them as less than 5 to 8 millimeters. If you take an 8 by 8 by 8 lymph node, that would be 0.27 milliliters, and that the average volume of the node studied, both in 2011 was larger than that at 0.34. If you look at the Kim study, it was 0.68. If you look at the original Lewis study, 0.49. So, I would argue that a lot of these studies are targeting lymph nodes already bigger than what has been described as small, but certainly something else to keep in mind. So what's next? How do we further answer these questions? Well, it's certainly more clinical experience, getting more numbers, more research experience, and more collaboration. I think working, educating in partnerships between endocrinologists, radiologists, surgeons, to understand when is this appropriate, and the indications tend to grow from there. How do we approach this at Mayo Clinic? Well, this began in 1991, mostly on patients that had distant metastases, and that was considered palliative for those. It's certainly evolved substantially over the years, and now we use this primarily for patients with disease localized to the neck. We've got a great partnership between our endocrinologists, our surgeons, and our radiologists, which again, I am. If we're going to see a patient for this, we want to have a positive FNA or thyroglobulin washout prior to injecting that. We'll make some exceptions if there's a cluster of nodules, they all look the same, and we biopsy one and it's positive, and the one right next to it, sometimes we'll just treat. But in general, anything that's distinct or remote, we'll want to have confirmation before we start putting ethanol into it. We do all these procedures under local anesthesia on an outpatient basis. We tend to do 2-day back-to-back treatment sessions. So pretty much anyone we see, we'll plan on doing it for 2 days, unless there's travel logistics or some other issue, or if it's just very small and we got complete coverage in one, sometimes we'll cut it short. But and then we follow these and we do subsequent treatments based on imaging features. So as Dr. Frich highlighted, we look for things like size, vascularity. The main things we focus on are retreatment. It would be volume changes, want to see those decreasing, vascularity decreasing or disappearing, and then in certain settings, serum thyroglobulin when that's helpful. And I think it's really important to emphasize this is, in our practice, very complementary to surgery. It's not competing with it. So we're looking at ways, can we delay surgery? Can we, in some cases, replace surgery for patients? But it's oftentimes we'll see patients with pretty severe disease and we say, all right, well, ablate, and then now it's time for surgery, and then we'll ablate. So there's different ways this can fit into the overall scheme. When we're considering, is this a surgical patient? Is this a ethanol ablation patient? It's important to keep in mind the risks of each. So the ATA Surgical Affairs Committee highlighted some of the risks of reoperative dissection, including hypoparathyroidism, both transient up to almost 50%, and permanent, anywhere from 0 to 9.5%, as well as the important one, they're both important, I should say, but vocal cord paralysis, either transient or permanent. So this is not without risk when we're operating there. Also, our own Mayo Clinic experience here with our head and neck surgeons published similar results here. When you look at complications occurring in about 6% of patients, hypoparathyroidism, unintentional recurrent laryngeal nerve paralysis, phrenic nerve injury, etc. The other important thing to look at is how many of these relapse. So, after about 2 years, 38% of them relapse. And of the relapses, almost half of them are nodal recurrences only. So even when patients are surgical candidates, disease is often going to come back. And oftentimes it's going to be nodal disease only. And then so we have to think, what's most appropriate for those? Is it repeated surgeries with the accompanying risks? Or as the ATA guidelines stated, keep in mind prior interventions, is that an opportunity for ethanol to play a role here? PEI risk. So if you look at the study that we're focusing on today, no major complications were reported related to PEI. If you look at 2015 study there, they showed a pooled PEI risk of 1.2% versus a reoperative risk of 3.5%. If you look at our Lewis study from 2002, we had no major complications other than transient discomfort at the injection site. Another one, 2007, 1 out of 16 had transient voice change, but no permanent voice changes and no other major complications. So in general, PEI, very low risk intervention. PEI in surgery, looking at costs matter. Obviously, this is going to be different for international audiences and things, but if you look at, Mayo Clinic here, we've got published results from 2002 and 2010, and then our 2022 results I list here are based on internal unpublished data. But if you look at, PEI cost versus surgery, while they're both rising, and PEI is actually rising more rapidly, still significantly less costly financially. One of the reasons, unfortunately, that in the U.S. that the ethanol ablation costs have gone up so far is related to some patent enforcement by one of the manufacturers. There are some potential strategies to mitigate that risk that I'm happy to talk about later if indicated or if someone's interested. But again, PEI doesn't need to replace surgery, while it may in some circumstances, but we look to see how does it complement surgery, right? I'm going to share an example PEI case here. So again, this would be a patient who came referred from an endocrinologist, was seen by endocrinology, and they triage these patients and decide, I think this would be a potentially good ethanol case. So they would refer them to us to review. We would discuss and either agree or disagree. This has been FNA proven to be recurrent papillary thyroid carcinoma in level 6. So we assess for vascularity, get volume measurements beforehand, approach it with either a 25 or 27 gauge needle, numb the skin and around it. And importantly, we put, lidocaine around the nodule, and that's a little bit of a test there. And so, I had one of these the other day where it was a little bit of a deeper location where we had said, this may put the recurrent laryngeal nerve in play, but, if surgery is really not an option and they really wanted to avoid surgery, so we gave it a try. But during the anesthetic phase, patient's voice literally disappeared. And so we say, all right, that is going to be too close. If any ethanol leaks out there, it's going to be, very much at risk for that ethanol bathing that recurrent laryngeal nerve. So then we just terminate the procedure during that anesthetic phase. That doesn't happen too often, but that is a nice built-in safeguard that we have to say, yep, we're going to be okay, or hey, we might get into trouble here. So presuming that doesn't happen, once we've done that, we'll put a needle into the node, and then we start injecting the ethanol, and you can see that hyperechoic change that we expect to see in a portion of it. And some nodes, you don't have to move the needle a whole lot, but my practice is pretty much to move that needle multiple times to make sure we get nice distribution throughout, top, bottom, anterior, posterior. Then we'll assess for vascularity, expect to see that vascularity resolve. So in closing for my comments here, I would really like to commend Dr. Frich and colleagues there. This was, I think, a great contribution to the literature. Like I said, large numbers of patients, longer follow-up. It's exactly, addressing the limitations that have been called out by the ATA and others as far as what do we need to do to advance percutaneous ethanol injection. We need more of it, though. We need more studies, more patients, more follow-up, more data. So let's do that. Comments on PEI, it's safe and relatively inexpensive. It's definitely repeatable. It's a nice way to address recurrent papillary thyroid carcinoma in the neck, and I think it should be employed complementary to surgery, not doesn't have to be us fighting with surgery, right? And I think a collaborative approach has been key here. We've got a great relationship with our endocrinologists, surgeons, and radiologists, and I learned so much from my partners, in those other departments there. So it's been a joy to do this, and I will close there and look forward to the discussion.
Thank you very much, both. Thank you both for wonderful talks. I see Mark Erkin is online, so if you want to start, I have several questions here.
No, I would also just like to echo my gratitude, and these were wonderful talks. Eyal, why don't you start off, and if there's time, I've got a handful of questions I'd like to ask as well.
Okay, so the first question is, Dr. Schmitz, you mentioned a leak from a lymph node that may happen during the treatment. So what does that mean in relation to pain, to complications, and specifically, what happens if you want to do surgery afterwards? Do you have fibrosis? Is the surgery more complicated, more difficult to do?
That's a great question. So I basically expect to see a little bit of ethanol leak out of every lymph node that we're doing. So there's a lot of times these have been FNA'd maybe in the morning, and then we do an ethanol ablation in the afternoon. So it might already have, several holes poked in it from the FNA. Also, like I said, if we're not seeing, with one needle poke, if we're not seeing nice distribution, we'll reposition that needle within it. So it's going to have multiple pokes throughout there. A little bit of, and when we're injecting these, we're injecting less than a milliliter on average for all these. A lot of times it's 0.2, 0.3, 0.4 milliliters in these small lymph nodes. So it's not a large volume that would be leaking out. We do try to minimize the pain by putting some of that lidocaine around the neck, but we don't completely deaden the neck either, because you can usually see the ethanol leaking out. But also if the patient says, hey, I'm starting to feel something funny, that's a secondary indicator in case we're somehow missing the visual cue there. As far as, I'm not a surgeon, and I don't want to be flippant as far as saying, oh, you can operate after that or not. I have asked our ENT surgeons both about, operating in necks after radiofrequency ablation inside thyroid nodules. Again, they've said for those, really not an issue. Again, usually we're staying inside the nodule and inside the thyroid the whole time. As far as the ethanol leaking out, I have not heard that it's any more difficult than a reoperative neck, but that's a great question maybe for some of our surgeons here. But again, these are patients who've already usually been operated on and already probably have some fibrosis happening, but I don't want to overstep my knowledge there. So.
Yeah, so Dr. Smith asks if there was any study comparing neck dissection after ethanol ablation, comparing it to necks without ethanol ablation. I don't think there is any study comparing dissection with or without.
I don't believe
prior.
so, but
Yeah.
again, I think that kind of ties into that same question, and that might be a great project, a great question to investigate. How much more challenging is it? Yeah.
So a question to either one of you: how after ethanol ablation, in many cases, you still have the lymph node in the neck. So you do an ultrasound and you see this abnormal lymph node. Whereas if you go to surgery, you can take it out and you have like a normal ultrasound. So in terms of the patients, how do they take it? How stress related is the follow-up? You have 10 years of follow-up. Every ultrasound is abnormal. What's your experience with how satisfied patients are with this approach?
So I think maybe it's a testament to our endocrinologists and how well they counsel these patients, but these patients come very well prepared. And the patients that I see, and maybe they're selected that way too, right? The patients I see are very happy to be either avoiding a present surgery or delaying surgery, and pretty comfortable with that. The idea that, we're going to hopefully treat it all in this session, but if we don't, it's still remains a very treatable disease, either with repeated ethanol or with surgery, not taking surgery off the table. So the patients that I see handle this really well. And again, I don't know if that's a self-selected population of the ones that make it to that point are willing to take that, or if it's a combination of that and our endocrinologists explaining it so well. I do know that there's some patients, like in my other practice, thermal ablation outside the neck, that might have a centimeter or sub-centimeter renal cell carcinoma, which, you could certainly observe with active surveillance, but they just do not want to know that they have any malignancy in them. And so they say, I need this ablated or operated on or something right now. And so there definitely are those patients, and maybe this would not be the best strategy for someone like that. I don't know, Dr. Frich, did you have anything you wanted to share?
So, no, first of all, I do agree with your experiences in what we see patients which are, well prepared and well aware of the limitations of the technique, and do actually know very well that they might have to come back several times for repeated sessions. And they also usually know that the risk of new recurrent lesions are there. And I think, like you said, it's more like a self-made decision, maybe in the beginning, that a self-made selection, which make these patients quite motivated for this kind of treatment and this kind of follow-up, and can live with the risk of having, having an active but indolent cancer in their body.
Okay. The next question is to Dr. Frich. Maybe some of the people listening to this session think about doing this procedure. So how difficult it is? How long does it take to master it? And how comfortable you feel doing it? Like after a couple of years you've been doing it? What do you think?
I think the procedure in itself is not too complicated, but of course you have to have some experience in doing the ultrasound guided techniques. So as soon as you learn the technique of the ultrasound guiding, maybe lesions which are maybe bigger, maybe not so small, the procedure in itself is quite uncomplicated. But of course you have to be aware of the complications, the risk of ethanol leakage, the nerve damage, transient voice changes, such things. So I think technically it should be quite easy to implement in many radiological departments, I guess.
Yeah. So we have a question from Dr. Marcello Samudio, and he asks if there's a size limit to a lymph node that you ablate with ethanol. And I want to add, is there any limit to the number of lymph nodes you would ablate in a session or over 2 days?
Yeah, I could answer to that.
Yeah.
We don't have any upper limit, but of course, these decisions are usually made in a multidisciplinary board. And of course, if you have like 1 or 2 lesions in 2 different regions, it might be less. You might not want to make surgery in 2 different compartments. Maybe you want to try ethanol ablations first as a first try. But usually we wouldn't choose ethanol ablations when you have at least more than 2 or 3 lesions in a region.
Now I want to challenge you. Let's say a patient had total thyroidectomy, had radioiodine therapy, and then on ultrasound has a small lymph node, let's say 1.2 over 0.6 centimeter. According to the ATA guidelines, we can follow this lymph node, active surveillance. There's an option to go to surgery. Why not go to upfront treatment with ethanol ablation? Why use it only after neck dissection when you have a second recurrence? Just your personal opinion.
My personal opinion on that is, I don't think the results would differ very much. Of course, if you do a dissection of the region, you might reduce the chance of having new recurrences outside of the one lesion that you actually treated. But besides from that, you could, I think, quite practically, you could give it a try and to see if that lesion actually is adequately treated and maybe disappears. But as of today, the guidelines are stating that you should do surgery as the first treatment with a lymph nodes in at least a non-operated neck region.
Yeah. So now many patients go to active surveillance. So maybe we have a middle ground between these two options.
Yeah.
Now the next questions. I think both of you do radiofrequency ablation, ethanol ablation, maybe laser ablation, there's ultrasound ablation. How do you choose the best tool to use for a specific location?
So for us, we've been very pleased with ethanol ablation for neck nodes. We do radiofrequency ablation quite a bit in other parts of the body, and especially for benign and malignant thyroid nodules. We found that radiofrequency ablation is more painful when we're treating something like a neck node than ethanol ablation, and it's more cumbersome. It's a bigger deal. Our practice, it's not everyone's practice, but our practice is to use moderate sedation if we're using radiofrequency ablation in the neck, and so that adds time, expense to the procedure. Whereas ethanol ablation we do under local anesthetic, it's faster, it's cheaper, and we have seen great results with that. So that's our approach there. We do laser for a smaller percentage of things. Usually when we're trying to get a really tiny nodule or a nerve or other things, we use it for some kind of boutique interventions. But I think radiofrequency ablation is a great option. But for some of these areas where they're embedded with muscles around there, you need to get quite a bit of a local anesthetic around there or hydrodisplacement to minimize the pain, at least in our experience. So ethanol works really well, so we prefer it.
Okay. The last question that I have, in my hospital, it was a bit of a challenge to get a hold of ethanol for these ablations. So could you expand as much as you can, not about the cost so much, but maybe about the availability and how easy it is to get the material to do these ethanol ablations? Or is it just a price issue?
Well, I'll speak at least for the US. Several years ago, there were multiple manufacturers of ethanol, and it was definitely not an issue with cost or availability. Then there was a company that enforced a patent on the use of ethanol and issued cease and desist orders to other manufacturers, so effectively taking them off the market, limiting it to one, and of course the price went up. And unfortunately, I did hear from some endocrinologists around the country who are saying, we can't afford this anymore. How do you work it? That's really unfortunate that people are getting priced out like that. I think that patent, one option is that patent's going to expire eventually, and hopefully it doesn't get renewed, and maybe that will open up options. What we have done and begun exploring here too is, having our pharmacy aliquoting that, for patients, because a lot of times, it comes like in a 5 ml vial. But if we know we're going to do a 2-day treatment, we can have the pharmacy split that into, sterile under the right conditions, under sterile aliquotes, and we can use that same vial, for that patient, as opposed to using 1 ml one day, wasting 4, seeing them back the next day, using 1 ml and wasting another 4. So that might be an option to explore either within single patients, or I don't know if that can be done for multiple patients. I don't want to, but that might be an idea to explore there. We have not had an issue with supply chain availability of it. It's just that it costs so much. And I don't know if Dr. Frich has other experience outside of the US with either of those.
No, it's an interesting question and perspective. The healthcare systems are, of course, quite different in Norway and the US. So we have like a public system, and the patient do not have to think about the cost. There are no insurance companies involved in such things. And to my knowledge, there's been no problem or any problems or challenges with availability here either. And as far as I know, the price has never been a discussion. So for in our part, we haven't had to met that challenge in our practice.
So we have one more question from the audience. So they ask, how do you measure success of ethanol ablation? Is it only structural, or do you also look at globulin decline? And is it influenced by the size, by the nodal burden, size, quantity? So the response to therapy, structural versus biochemical.
Yeah, I could start. So it's also interesting. We have, for the studies, we use the treatment criteria for each single lymph node treated by ethanol ablations. Usually we would treat the lesion until it has reached either one of those criteria, either disappearing or normalizing. And in a lot of cases, we also do the final aspiration and the washout samples to confirm the successful treatment of each lesion. But then when it comes to, of course, several lesions, new lesions in the same neck region, lesions which are uncertain or indeterminate, it's actually no routine, but in the cases where we are in doubt about the future treatment, we usually refer the cases to a multidisciplinary discussion in the multidisciplinary board. So, but for each single lesion, we usually follow the criteria as I mentioned in the study.
Okay, thank you very much. So we're nearing the end of the hour. Mark, if you have any last questions.
Yeah, thank you. And thank you for all these questions and excellent responses. I have 3 questions for Dr. Frich and Dr. Schmitz. Either one of you can answer these. Number 1, do you notice a difference between cystic versus solid lymph nodes with respect to response? Number 2, have you learned anything from the reoperative cases on patients that were resistant as to what may be underlying causes for resistance to ethanol ablation? And my 3rd question, and I apologize for loading these on here, is have you tried any histology other than classic papillary? Have you looked at subvariants or any more aggressive forms of thyroid cancer to use ethanol ablation? So first question, solid versus cystic. Second is causes for resistance. And the third is a more aggressive histology here.
I'll try to answer those quickly, and then Dr. Frich can, if he wants to comment. Cyst versus solid have not. If we're talking about, the typical small cystic size, they tend to respond really well. Differentiating that from cystic thyroid nodules that can be, several centimeters, where we'll treat those with ethanol, and it may take a couple treatments to get them to sclerose down. But if we're talking a small cystic component of a lymph node, those tend to respond very well because we get great ethanol distribution throughout the cystic and solid components there. As far as surgical outcomes, we have not. I think you've given us another great, opportunity to pursue here, looking at, surgery after PEI for complications and for, histological lessons. And then finally, have we used it for anything else? Yes, we have. Not a lot, but I remember asking Dr. Lewis exactly that question. Hey, this is a medullary. They're asking us to do why, and kind of strange cases, right? It would be uncommon cases, but certainly we've done. Usually we don't, but we have done it for a few more aggressive thyroid cancers in very special circumstances.
So tall cell variants. Or any other more aggressive forms of disease. Do you have any comments on that?
I don't.
Okay. All right.
Yeah, just like some seconds, I can just mention that we had some discussions in my department that we do have an impression that this lymph nodes with cystic changes maybe are responding better than the more solid lymph nodes, and that could be due to the better distribution of the ethanol in the lymph node. So, but we wanted to take a look at that in this study, but we didn't have the data, or the data wasn't solid or good enough to look into it. So hopefully we can do that in the study in the future to see if there's any difference between the solid cystic structures ahead of the treatment. When it comes to treatment in, as you said, more aggressive cancers or different cancers, we have been treating some metastasis from medullary thyroid cancer, trying to find those patients, and also planning to do a study on those patients because there is a lack of published reports on ethanol used in medullary thyroid cancer. But we have tried it, have seen response in some cases, but we have to do more research to see if there could be comparable results with the results that we saw from papillary cancer.
Great.
Thank you very much for wonderful talks and very thought-provoking discussion. Thank you for both of our guests and for our audience. See you next time.
Yes, one quick note, next week we will have tumor board cases from the Cleveland Clinic. Dr. Joseph Sharp will be joining to present some challenging cases. So hope all of you will come back next week to be a part of that. Thanks, everybody.
Sure.